Good morning, dear colleagues. I have the difficult task to tell you something about response-adapted treatment algorithms. Where do we stand? Could be the subtitle of this. Thank you. Thank you for switching it on. And just to show you in which field we are, I start with 3 cases, and at the end of my talk, I give you my answers to these questions. And the first patient is one with esophageal squamous cell cancer. He achieves, according to the investigator, a good response after carboplatin, paclitaxel, and 41.4 gray cross regimen. And the question that was asked to me during a meeting was, is the operation still needed? We don't see any tumor at restaging, or should we just watch and wait for this good responder? Second scenario is a patient with esophageal adenocarcinoma. He was monitored with metabolic response imaging with FDG PET during neoadjuvant chemotherapy. Investigators saw no metabolic response following 6 weeks of neoadjuvant FOLFOX. And they asked the question, should we switch to carboplatin, paclitaxel, and radiation therapy? Should we operate right away? And the third scenario is in gastric cancer. People asked me, we did not see any histopathological response after 4 cycles of FLOT. The tumor stage is YPT3 and 2. Should we follow the guidelines and give 4 cycles of post-operative FLOT, or should we switch to an alternative regimen, or should we give no adjuvant therapy at all? So these are the 3 scenarios, and I will guide you a bit through the data and give you the answers to these questions at the end of the talk. So stay tuned. This has been shown already. It's the ESMO Guidelines here for esophageal cancer, but it's very similar to what is recommended in gastric cancer. And this slide has been shown several times already. Important is that we have different recommendations for squamous cell cancer and adenocarcinoma. For squamous cell cancer, there are 2 strategies. The one is the neoadjuvant strategy with obligatory resection. The other one is the definitive chemoradiotherapy strategy with potential of salvage resection in non-responders or in terms of local relapse. And then for the adenocarcinomas, again, we have the neoadjuvant CROSS regimen as one recommendation, but as an alternative, we have the gastric cancer algorithm with perioperative chemotherapy. So just to set the scene. And let us go back to the first case. It was a patient with squamous cell cancer of the esophagus who received the treatment according to the CROSS study, and you are all aware of the results of the CROSS study with a good effect for neoadjuvant chemoradiation, especially in the subgroup of patients with squamous cell cancer. They benefit quite a lot from this treatment. And it is important to note, Marcel Verhey showed it already yesterday, that following neoadjuvant chemoradiation according to CROSS, you see 29% of complete histopathologically confirmed complete responders. And this number is even higher when you go to the subgroup of patients with squamous cell cancer, where the number was 47%, with some caution because the number of patients is still limited. But I think, according to our experience, it's quite realistic that this treatment works well. Now, I want to make you aware that in the ESMO guidelines, there is really a distinction between these 2 strategies. And when we recommend neoadjuvant chemoradiation, we recommend a radiation dose of 40 to 45 gray. Whereas when we recommend definitive chemoradiation, the recommended dose is 50 gray, and Marcel yesterday showed already nicely that there are attempts with novel planning technologies to increase this dose. So just to make you aware that this is the recommended standard. So standard after 40 to 45 grays is to proceed obligatorily to resection. Is there a reason for doing that? I would say at the current time point, yes, there is. This is just an example from a patient from my treatment history. It's still a picture I took from Munich. We saw this situation after neoadjuvant chemoradiation, still some tumor mass, but endoscopically a very good response. There was no tumor visible anymore. So in addition to that, we also did a PET, and the PET did not show any tumor metabolism. So according to clinical response criteria, something we might consider that we could do a watch and wait strategy. We did not do so in these times. This patient underwent resection, and at meticulous investigation of the tumor, of this part of the former tumor, it was still visible that some residual tumor cells could still be identified by the pathologists. They also did immunohistochemistry staining and interpreted this finding as being some sort of residual, minimal residual tumor in the former tumor bed. What about the PET investigation? This is a paper from Hinrich Wieder, also from that time, and he nicely showed that if you monitor chemoradiation with PET, you may see an early decrease of the tumor FDG uptake, which occurs as early as 2 weeks after the initiation of chemoradiation. The tumor FDG uptake may even decrease further during the further course of treatment. So it's quite interesting, probably, to do this type of metabolic response monitoring. And it would certainly also be interesting for future study designs to say, okay, if we can see an early response during chemoradiation at an early time point, we may consider what to do with these patients. Are these good candidates, for instance, for definitive chemoradiation because they are good responders? But there are also some caveats. For instance, there is the caveat that Angela Riddell yesterday mentioned already of false positive findings. Here is, for instance, the example of a patient who responded with an esophagitis. So it looks like there is tumor somewhere metabolically, but this was just a correlate for radiation-induced esophagitis. And also, when you look at all the data that investigated this approach, it is clear that this early or later metabolic response is associated with a good prognosis, but there is one unresolved problem, and this stands here: the correct identification of patients who achieve a true histopathologically confirmed complete remission is still an unresolved problem. So whatever you do endoscopically or with metabolic response monitoring, you will not, with a high specificity, identify the complete responders. This is also the reason why some groups, including the Dutch group, and I show this example here, are currently conducting trials how to monitor the patients who might be good candidates for a non-operative approach. This study here is called the ESMO trial, and they are doing diffusion-weighted MRI and endoscopy and all these things that can be done. But I just want to make you aware that this is really still under evaluation. So my conclusions at that point are just make you aware that you take your decision here at this time point if you go to a neoadjuvant strategy, including obligatory resection, or if you go for a definitive strategy with a higher radiation dose. My conclusion would be that the decision about neoadjuvant or definitive treatment should be taken upfront by the tumor board and not during treatment at the current time point. Response evaluation during or post-chemoradiation is challenging with a lot of caveats, and a prospective randomized trial comparing neoadjuvant versus definitive chemoradiation therapy with modern technologies and with modern response monitoring is something we probably need. And we are in discussion with the Scandinavian group, with Magnus Nielsen, to implement something like that. So I go to the second scenario. You remember this adenocarcinoma patient who underwent neoadjuvant chemotherapy with the FLOT regimen, and there was no metabolic response seen during treatment. So this is a scenario which you know very well, also from the times when the Municon group was still active. It was exactly that, the approach that was chosen by this group, with an early metabolic response monitoring after 2 weeks. Other groups postponed this second PET investigation to a later time point. For instance, the Americans in the Sloan Kettering did it after 6 weeks. And what the group from Munich nicely showed, that there is a threshold of decrease of SUV, of FDG uptake in the tumor. Professor Weber defined this threshold being most accurate at minus 35% decrease of the FDG uptake. And if you do so, you see a group of metabolic responders and no responders with a very different prognosis, long-term after resection. And based on this knowledge, we started the Municon trial that was published in 2007. It's already 10 years ago now, where we did an induction chemotherapy for 2 weeks, and then a second metabolic response assessment with continuation of the chemotherapy in case of metabolic response, and with discontinuation of this strategy and immediate resection in case of metabolic non-response. And you may remember the survival curves that expectedly, according to the study hypothesis, we saw a good survival in the PET responders and a worse survival in the PET non-responders who went to immediate surgery. But importantly, compared to historic controls where all the patients received the 3 months of preoperative chemotherapy, there was no loss, no decrease in survival for the non-responders by omitting chemotherapy. This was the message at that time point. And then, of course, we asked in 2007, what can we do to improve the poor prognosis of the PET non-responders? Obviously, it does not really make sense to continue the same chemotherapy, but can we do anything else to make their prognosis better? And this is still, in my view, an unresolved issue. I just show you the several designs that are currently studied. We started with the Municon 2 trial, where we added some form of chemoradiation to the non-responders. It was published in 2011. It did not show that this form of chemoradiation improved the prognosis. It remained poor. And then there are several ongoing but not yet shown or not yet fully published studies, like the Australian doctor study, the US CLGB 8083 study, the UK Scope 2 study, and the GastroPet study from Czech Republic. And I just show you the designs, just to give you an idea what investigators who took up the Municon idea had as an idea to improve the prognosis of metabolic non-responders. Here the Australians do the PET scan, and for the responders, they continue with cisplatin 5-FU. For the non-responders, they randomize between a FLOT-like regimen, DCF, with or without radiation therapy. Some results have been shown at ESMO 2016, but I will not show you the results. Nothing is fully published yet, and some of the results are very difficult to interpret, I have to say. This is the design of the US colleagues, CLGB 8083. They randomized between induction FOLFOX6 or carbotaxol for 6 weeks. Then they do the second PET scanning. After the PET scanning, they add radiation, and according to response, they maintain the initial chemotherapy backbone or they switch it in the non-responders. Again, this study has been shown at a previous ESCO GI meeting, but results are difficult to deal with, in my view. Maybe I'm not fair. This is the design of the Scope 2 study, quite complicated, I have to say. Here they take the non-responders, the PET non-responders to induction therapy, cisplatin capecitabine, and randomize them to 4 groups. And the question is, can you maintain the same chemotherapy, or should you switch chemotherapy to carbotaxol? And which is the radiation dose that you should use, 50 or 60 gray? Another design. And this is the nice study design from the Czech study run by Radka Obermanova. It's a phase 2 study. Patients receive induction chemotherapy with FOLFOX or FLOT, and then for the metabolic responders, they continue with what works, and for the metabolic non-responders, they switch to chemoradiation in CROSS, and here's the primary endpoint, which is based on our seroresection rate. This gives you just a rough idea what is currently studied, but no definitive results have been published yet. So this is where we stand. And please don't forget that these studies are extremely complex in all regards. You need a perfect multidisciplinary setting, a perfect communication between all the disciplines involved: nuclear medicine, radiation, surgery, medical oncology, radiation oncology, the patient who needs to understand all that. And you need funding, and this is also a complicated issue. We experienced that in the EORTC GI group. Then I switched to the last setting. You remember it was the gastric cancer patient who underwent standard FLOT and who did not achieve a response. YPT3 and 2 and no regression. And I go back now to works from Karin Becker from Munich, who defined the histopathologic regression score in gastric cancer and EG junction cancer patients. And you may be aware that she defined a grade 1. 1A is a complete remission, and 1B is a subtotal remission with less than 10% vital tumor cells left in the initial tumor bed. And grade 2 is an intermediate response, and grade 3 is no response. So this is the basis for her work. And she also made us aware that if you want to do this Becker classification, you really need to look at the whole tumor bed. It's not enough to take a biopsy from somewhere and to say, I don't see tumor cells, so it's Becker 1A. It doesn't help at all, to be honest, because she nicely showed that in the luminal side of the tumor, you often see more response than in the external sides of the tumor. This is something she nicely showed in this paper. And it really should make you aware that if you go into the tumor endoscopically and you don't see any tumor left, and even if you take some biopsies, there's still maybe tumor in the peripheral sides of the tumor. This is shown here in this slide. But she could nicely show that if you do this form of histopathologic assessment accurately, you get a nice distinction of the prognosis of the patient, with a very good prognosis in the 1A and 1B responders and a poor prognosis in the intermediate and non-responders. She also showed, like later Lizzie, that the YPN status is highly prognostic. She showed in the same paper that having positive lymph nodes following neoadjuvant therapy, this has a major impact on prognosis. We did a combined analysis of patients treated in Germany with taxane-based neoadjuvant treatment, and this was published recently in the European Journal of Cancer, and it was nicely shown that patients achieving a complete response with a much higher likelihood have an intestinal subtype of gastric cancer than a diffuse subtype of gastric cancer. And this is also true when you combine 1A and 1B. And with taxane-based regimens, you achieve something like 30% complete responses in the intestinal subtype and much fewer in the diffuse subtype. And this here is highly interesting because also in this taxane based regimen treated patients, you can see that there is a difference in prognosis. If you go to this graph, for instance, between the good responders 1A and 1B and the poor responders grade 2 and 3. And this here is highly interesting because when you distinguish between the different subtypes of gastric cancer, you see that this is true, according to this analysis, in the intestinal subtype, where Becker grade distinguishes nicely the prognosis, but it was not true in the diffuse subtype, where it was not predictive. This is hypothesis generating. Don't take this as the truth, as the Bible, but it's hypothesis generating, and it's interesting. And this is the recent paper from Lizzie Smith, a retrospective analysis of the MAGIC data, so no taxane, but epirubicin platin 5 if you treated patients. And she also could nicely show that regression grading according to a different system, the Bundard system, is highly prognostic. distinguishing good responders between poor responders. But if you add to this consideration the YPN status, the nodal status, this remains the only single prognostic factor. And here you have a group with an extremely poor prognosis. It's the non-responders with positive lymph nodes, and you still have a problematic group, responders with positive lymph nodes. So lymph nodes are an extremely important factor. And based on this work and the work of Karin Becker, we are opening this year an EORTC trial which considers exactly this poor prognostic subgroup of gastric cancer patients, where patients who remain nodal positive after standard chemotherapy with a platinum, 5-FU, mostly taxane, they will have the possibility to undergo randomization between the ESMO recommended standard of care, which is continuation of the same regimen, or an immunotherapy where we will have the chance to combine ipilimumab, a CTLA-4 inhibitor, and nivolumab. So this trial is under preparation. It will probably open in the 3rd or 4th quarter of the year 2018. So I promised you to give you clear answers to my difficult questions at the end of this talk, and I will do that now. And so we have this patient with an esophageal squamous cell cancer, good response after carboplatin paclitaxel and 41.4 gray. Is operation needed, or should we watch and wait? And my answer at this point is operation is recommended until further evidence is published. And I just want to make you aware that the way how we wrote the ESMO guidelines is that the decision should be taken here. Here in a qualified tumor board, you should take the decision if you want to go for neoadjuvant with a reasonable radiation dose, or if you want to go for definitive chemoradiation with a higher radiation dose, and don't decide your strategy at a later time point, currently. Then esophageal adenocarcinoma, no metabolic response following 2 or 6 weeks after neoadjuvant FOLFOX. Should you switch to carboplatin paclitaxel and radiation therapy, or maybe operate right away? My answer is don't measure metabolic response outside of a clinical trial. This issue is complicated and needs clarification in clinical trials. I don't know if you agree with this answer, but we can discuss it later. And now gastric cancer, no histopathological response, YPT3 and 2, following 4 cycles of FLOT. Should we give post-operative FLOT, switch to an alternative regimen? Should we give no adjuvant treatment? My answer is no one knows the answer. Enroll in EORTC 1707 VESTIGE. I showed you the design. I thank you very much for your kind attention. I hope that I did not run too much over time. I think it's still fine. And so I want to make you aware that in 1 year from now, 8 to 11 May 2019, we all will meet in Prague for the International Gastric Cancer Congress, which will be the next exciting event after this event here. So please take it to your calendar. Thank you very much for your kind attention.